will be doing more teleconferences and Zoom calls like this one. The Australian government directives as of 25th March, that was 2 days ago, that sent a little bit of a shockwave through the country. All elective surgery category 3 and non-urgent category 2 has been cancelled, has been put on hold. That was taken back a few hours later, but reinstated by the hospitals. So at this point in time, cancer-related measures, so cancer refers to category 1, and urgent category 2 are not affected. And I believe the plan from the Australian government is that category 2, that includes cancer-related diagnosis and treatment, will not be affected ever. That involves the diagnosis of cancer. So that means, for example, investigations, for example, for vaginal bleeding, for other symptoms, surgery, medical imaging. All these things will not be affected, and will the plan is that this will continue to take place in Australian hospitals. What will also be maintained is to treat cancer, such as that patients can have surgery, patients will continue to have chemotherapy, radiation treatment as scheduled to the best of our abilities. Finally, category 1 also includes conditions that could worsen if we would wait. So also these conditions are also category 1 and will be continued. Investigations or treatment of recurrence, of course, that will continue, and follow-up will continue to the best of our abilities. The role of surgery in patients with uterine cancer, ovarian cancer, cervical cancer, and bowel cancer is well established, and we all, especially medical and nursing staff, are well aware of that. So I just thought I'd share with you a few things that we know. We know that healthcare resources will be limited. Operating theaters, some operating theaters will be refitted into ICU, intensive care beds. Intensive care beds will be sparse. Ward beds may be used for all kind of different things. Doctors will be attending to urgent COVID-19 patients. I believe none of us in Australia will have an idea how this is really going to play out, and I'm really keen to have our overseas presenters and experts' opinion. We all know also that surgery is an important life-saving part in gynecological cancer treatment. We finally know that patients with suspected or proven gynecological cancer who are COVID negative will be treated as usual, pending available resources. Medical imaging, pathology, and so forth should remain available to patients locally, will remain open and may be used more often in the next few weeks. Telehealth will cover many aspects of follow-up and healthcare delivery. What we know from COVID-19 so far is that symptomatic patients, these are patients who are short of breath, these are patients who have pneumonia. If we would take them to the operating theaters for surgery, they have a much higher surgical complication rate. So ideally, we will refrain from that. COVID-19 patients also can infect healthcare workers who could get killed. And there are many examples, again, from overseas. It is important that if a patient gets sick with COVID-19, it is very important that we prioritize the COVID disease over gynecological cancer. Uterine cancer is typically managed surgically. However, there are alternative options. One option is that medically compromised patients can have intrauterine progestins. So we can delay surgery if needed. To fit an intrauterine progestin into a patient's endometrium or uterus is a minor procedure, and we can do that. For intermediate and high-risk uterine cancers, we may have to accept a delay, but a delay of less than 6 to 8 weeks should be acceptable. If comorbidities are of concern, we want to treat them first. And actually, there is some literature available that if we look after sick patients with uterine cancer who have multiple medical comorbidities, if we treat the medical comorbidity first, patients will do better. Follow-up for uterine cancer, we believe, is important and may potentially be very helpful. However, travel may be difficult. Follow-up may involve telehealth. Symptoms will need to continue to be investigated, for example, bleeding or pain or any other symptoms. Medical imaging should be available, and blood pathology should also be available, and there will be local GPs available to help us with investigations, but your local gynecological oncology care provider will be able to manage that. In terms of ovarian cancer, symptoms should be evaluated regardless: bloating, fullness, bowel symptoms. I could imagine that Australia will be able to continue assessing tumor markers, medical imaging such as ultrasound, CT scanning, or PET-CT scans. Some of these tests can be arranged by the GP, some of these tests can be arranged by the gynecological oncologist remotely. However, we will need to see patients prior to any surgery. We will need to continue them, and ideally the wait for that will be a week, just really so that patients can receive a plan and can be assured. Some patients will require surgery. That surgery could be laparoscopic or open. However, we will be keen to avoid surgery that requires an ICU admission. And maybe chemotherapy can help us in that time. If we plan to take a patient to surgery, we aspire to take a patient to surgery within 4 weeks. Some patients will need upfront chemotherapy with investigations after 3 cycles. And again, follow-up will involve telehealth. Medical imaging and CA125 monitoring should continue to be available. There is a limited role of physical examination in ovarian cancer anyway. So I think ovarian cancer follow-up is an ideal candidate in the setting of ovarian cancer. Should a patient develop recurrence during these difficult times, we need to determine individually how we can help and what we can do ideally. In terms of cervical cancer, we know very early cervical cancer, and honestly, everybody would think that can be easily delayed for about 8 weeks. There should not be a problem. There should not be an issue with that. Localized cervical cancer, such as stage 1B, patients usually receive a radical hysterectomy and a node dissection, and ideally these patients are treated within 4 weeks. Locally advanced or advanced cervical cancer, the treatment of that is usually chemoradiation. And I don't think that chemoradiation will take up resources that will be needed otherwise. So I don't think that there will be a lot of disruption there. Again, for follow-up, telehealth is going to play a major role because the majority of patients who are concerned about recurrence develop symptoms, and these are warning symptoms and can be investigated. In terms of vulval cancer, there are 2 issues: the vulval tumor, the primary tumor, and the groin nodes. Surgery ideally surgery has a very important role in the treatment of vulval cancer and should ideally happen within 4 weeks because we are concerned that the delay of longer may result in disease progression. Again, follow-up. Even today, when I look after patients who live in remote areas, we teach them self-examination. A physical examination is feasible through the GP, but not through telehealth. And the ultrasound of the groins will remain possible through remotely. So in summary, coming to the end of my presentations, patients with confirmed COVID and pneumonia, so these are sick people, avoid surgery. unless for life-threatening reasons. Because if you have to do an operation on a patient with pneumonia, the risk of harm to patients can be significant. COVID patients need to be isolated and need to have treatment for COVID. Patients who don't have COVID-19, we try to treat them as usual as possible. Symptoms should be evaluated to exclude or confirm cancer. Surgery will continue to be offered for patients, providing the resources are available. And follow-up may also continue, but should avoid unnecessary face-to-face consultations. So we don't want to see clinics and waiting rooms full of patients, but we want to make use of telehealth. I received one question up front that I would like to address here: palliative care. What's going to happen with palliative care service? So obviously I don't know. Answer number one. Secondly, I believe palliative care service will be reduced, especially in the public sector, and will be reactivated once the crisis is over. However, physicians, GPs, and most doctors are trained to palliate the most common symptoms. And certainly, I would be very keen that if a patient requires palliative care, that she contacts a medical practitioner for help. My last word is to all patients: stay connected. I definitely, I have no conflict of interest in regards to Facebook, but Facebook has been a blessing for a lot of people because it allows people to stick together, to form groups, and many hospitals, care providers, gynecological oncologists will have their own Facebook pages, including the Center for Gynecological Cancer Research, and many of the gynecological cancer treatment team members. And finally, if you're interested in this presentation, you can download it from this website, and I'm sure we can upload it also to the Center for Gynecological Cancer Research website. Thank you very much.
Great. Okay, so now I will try again to share the right screen. And I hope you can see this screen now and the interview starting. Let me know if not, please.
Yeah, I can see it. Go ahead.
Okay. So it is my absolute pleasure and honor to welcome Professor David Patterson, Senior Infectious Disease Specialist and Professor at the University of Queensland to this webinar. Professor Patterson will speak about hopes for COVID-19 vaccine or treatment. David, please.
Thanks very much, Andreas, and hello, everybody. I thought I would just start by talking a little bit about what this COVID-19 and coronavirus is, and then talk a little bit about what are some of the advances going on, and then thirdly, to talk about some practical questions, particularly how you might actually protect yourself. So just to start with, we talk about coronavirus, and in fact, coronaviruses have been known for more than 50 years, and they were first discovered as a cause of the common cold. But there's not just one type of coronavirus. There are many different types. Some types only infect humans, and some types are found in animals and also birds. The bad thing happens when an animal or bird coronavirus somehow crosses over the species barrier and infects humans. Because if that occurs, no human has got any natural immunity against these animal or bird coronaviruses. And that's exactly what's happened. We think it's a coronavirus that's come from fruit bats. People have never seen this coronavirus before, and that's why it's become such a huge health issue, because we don't have any natural immunity. There was never a vaccine available. There was never a treatment available. And that's why it has spread worldwide. And I'm sure everyone knows that it started in China, and as a result of international travel has spread particularly to Europe, Italy, Spain, France, the UK, and now just about every country in Europe. Iran has been a major place that's been affected, the US, and of course here in Australia, and as well in New Zealand. If a person gets infected with this novel coronavirus, some people, particularly young people, might not have many symptoms at all, maybe just a bit of a cough and a sore throat, which goes away rapidly. But most people would have a fever, they might have some chills, they would have a cough that was pretty persistent, and in some people that can deteriorate so a person would get short of breath. And in that situation where a person was feeling short of breath, even when they're resting or just after fairly minor exertion like going in the shower and drying themselves off, that's really an indication that the lungs are getting a significant infection with this coronavirus, and that
So sorry, the video just stopped. So I have to try to get it back. Sorry, the video just stopped. I'll have to try to get it back. So just bear with me. And I'll try to find where David was at.
it's coronavirus, and one is an old malaria drug that also, we're actually going to compare two old drugs. One is an old HIV drug that does seem to have activity in the test tube against this coronavirus, and one is an old malaria drug that also seems to have activity against the coronavirus. Now, because 80% of people just get better completely by themselves with coronavirus, to determine that one of these treatments, the HIV drug or the malaria drug, whether they truly work, we have to get a large number of people. And in fact, we're going to get more than 2,000 people in this trial to see if these actually do work. Now, you've also heard, I'm sure, a lot of discussion about the vaccine for this coronavirus. And there are a number of groups. One of the biggest groups is here in Brisbane at the University of Queensland that are working on this coronavirus. Now, unfortunately, those efforts, even though there's a lot of time and effort and money going into them, it is likely that there will not be a vaccine until next year, until 2021. So at the moment, it really boils down to prevention and treatment as best we can at the moment. Now, I want to sort of address some of the ways that we can prevent it in the absence of a vaccine. So I've got some questions that some of you have sent in. And one of the questions is, I'm due for my checkup at a large hospital. You know, I'm wondering whether the risk of going to the hospital and potentially being exposed to someone during my traveling or waiting in the hospital might outweigh the actual benefits of having that checkup appointment. And I guess the answer to that is really many hospitals are now turning to something called telehealth. And that's usually when we have a video conference, sometimes just a phone call, where if we're going to discuss firstly how a person's going, what their blood results are, perhaps the results of scans, we can do that by telehealth. And I think increasingly certainly over the next 3 to 6 months, that is likely to be the way that you have your checkup with your gynaecological cancer team. Now, obviously, some people are in the midst of receiving treatments, for example, chemotherapy. And, you know, one of the big questions there is, you know, I'm actively receiving chemotherapy. What is my risk of getting this COVID-19? So I guess while we don't have a lot of data yet, we do think that a person may have a risk of getting more severe disease if their immune system is suppressed, for example, by chemotherapy. And so we've got to have some very clear advice for you. And the advice would be as follows. Certainly when you're out and about, try whatever you can to think about where your hands have touched. And clearly we don't want to be shaking hands with people anymore. If we've touched, for example, a door handle, we need to follow that up with some alcohol hand rub or regular hand washing to keep our hands clean. We also have to be clear and to remember that we don't inadvertently touch our nose or our eyes or our mouth, because that's a way this can be transmitted, from touch of a contaminated surface, and then we touch our mouth or our eyes or our nose and transmit the virus that way. I don't recommend people wearing gloves or wearing masks when you're out and about, because the trouble is that they can lead to a false sense of security. And obviously there's also issues with very short supplies for doctors and nurses with things like what we call personal protective equipment in the hospital setting. So I'm not going to advise that you go out and about wearing masks or gloves. Now, if you are out, for example, at a doctor's appointment, we know that the virus, if someone coughs, only goes about 1 meter into the air. It doesn't get up into the air in a great amount. And so we recommend that a person should be about 1.5 meters at least away from someone else if you're sitting waiting for an appointment, for example. Now, if you've got a family at home, great. But again, particularly young people, particularly children or teenagers, you know, while we're happy, you know, for hugs, I don't think we really should be now being sort of into kisses or, you know, sharing kitchen utensils, for example, you know, the way we normally do when we're showing love to our family, particularly young children, grandchildren, for example. You know, we do have to be more vigilant in that, vigilant about those sort of things now. So there's been advice, I'm sure, that people have heard from the government about how big a group a person should be in. And in general, we try to reduce the number of people gathering together at any particular time. And a lot of our meetings now, you know, particularly, for example, if I know some of you do some counselling or coaching of students, I think we're going to increasingly get used to this sort of concept of doing it by video. A couple of final things, specifically, is there any increased risk, for example, with genetic mutations that lead to an increased likelihood of ovarian cancer? We know about the BRCA1, for example. There doesn't seem to be an association with that and development of COVID-19. So all in all, I don't believe that a person who has had gynaecological cancer in the past and has recovered from that is going to be at a higher risk of COVID-19. It is slightly different if a person is actively undergoing chemotherapy or is recovering from recent significant surgery. And I've explained, I hope, to people, how you can potentially avoid getting the viral infection if you've been in those particular situations. So I wanted to just keep it quite short. So I'd be happy if Andreas has some further questions to make things clearer for you. Thank you.
Thank you. Thanks very much to David. Andreas, do you want to say something in between, or otherwise we'll pass on to Jeffrey now to speak a little bit from the perspective of chemotherapy. Jeffrey, if you wanted to show your video, maybe.
Sure, Monica. Can you hear me?
Yes.
So in terms of chemotherapy, I think that we would still proceed as usual with curative chemotherapy, because I think that the risk of the cancer causing more harm and potentially mortality is greater if we don't treat it. So all patients who needed neoadjuvant chemotherapy, for instance, in stage 3 and 4 ovarian cancer, will still get their chemotherapy. Obviously, with chemotherapy, I would also take preventative measures such as give prophylactic GCSF on a day after chemotherapy to minimize the risk of neutropenic sepsis, and that's allowable and also funded by the PBS for chemotherapy that can cause neutropenia in about 20% of patients. So that is something that I would do. If patient has early infection or recurrent urinary infection, for instance, I would introduce empirical antibiotics or prophylactic antibiotics to prevent simple things like urine infection. So that can certainly be done. And thirdly, if patients are prone to getting viral infections such as shingles, I would also consider putting patients on antivirals such as Valtrex is one drug that we use commonly preventatively. In terms of trying to minimize other infections, I would recommend that patients get their seasonal flu, influenza vaccinations, which is coming up in the next week or two. Likewise, the older patients who qualify for varicella-zoster vaccine should also be getting their vaccines for varicella-zoster before starting chemotherapy if possible. I will now move to the question that has been sort of posed to me on the email that was sent to me. So the first question I have received is someone asking about starting chemotherapy soon and is currently self-isolating. Will they still get chemotherapy treatments in view of the shutdown? So the first question is that if you're being quarantined for COVID-19, that I would say that it is probably advisable to wait until the quarantine period is over, which is usually about 2 weeks, and you do not have any positive signs of the virus anymore before we proceed with chemotherapy. And if you're well and recovered from the viral infection, we can then proceed. 2 weeks is not such a long time to wait, even if you had stage 3 or 4 disease. But patients who are extremely sick with ascites, I would then consider it on a case-by-case basis. In that situation, maybe the ascites can be drained to relieve symptoms and wait for the virus to clear before we start chemotherapy. The second question is, how long does it take for someone's immune system to recover after an 18-week course of chemotherapy? So I would say that the immune system would reconstitute and recover usually 3 to 4 weeks after the completion of chemotherapy. but sometimes patients might have a low lymphocyte count and may be still at risk of picking up viral infections such as COVID-19. So therefore, the risk is still there, and all the precautions that apply to the general population will need to be adhered to: hand washing, social distancing. But even more, I think if you can isolate yourself for 4 to 6 weeks after completing chemotherapy, that would be much better. Obviously, you can certainly, if you're living with a partner, the partner can do the day-to-day chores like shopping and going out. And if you can stay at home and maybe if you need to exercise, just do it when it's not too busy in your suburb. So again, try as much as possible socially isolating until your immune system's stronger, usually 4 to 6 weeks after the completion of chemotherapy. The next question I have is a lady with stage 3C high-grade serous ovarian cancer and undergoing a 4th-line treatment and is quite well. The question is, if she was to isolate without her family, how soon after finishing chemo would her immunity start to improve so that she could rejoin them? It's a difficult one, this one. In the setting of treatment for palliative chemotherapy, the question is whether there is a substitute for chemotherapy, whether you can go on to oral chemotherapy such as cyclophosphamide or oral hormonal treatment such as tamoxifen, etc., to try and minimize cytopenias or risk of neutropenic sepsis. If you could go to a sort of a lower toxicity regimen, that would be good. But if you can't, and you're having weekly chemotherapy, for instance, then the risk of infection is always going to be there. So in that situation, I think then the question is, can you have a break from chemotherapy during the COVID season? So if the answer is yes, you can have a 3 to 6 month break from chemotherapy. That would be a better option if you're having chemotherapy in a palliative setting. So that's the kind of long-winded answer. I'm happy to sort of expand on that if possible. The next question that I received was, there's a 61-year-old lady feeling very fit and well. I think I know this person, who's had chemotherapy for stage 3C ovarian cancer, and she's now on a trial, the Athena trial with maintenance PARP inhibitor with or without immunotherapy. When you're having immunotherapy and olaparib, the immune suppression is not so great. So I would say that your risk of picking up infections such as COVID-19 would be near to the normal population. Obviously, that will depend on the patient's comorbidities, if they've had diabetes or heart disease, etc., etc. All that will compound the risk of picking up viral infections. So if your white cell counts, particularly your lymphocyte counts, are within normal range, then I think the risk of getting COVID-19 is the same as the normal population. So I don't think that it's much higher than the average person. That said, I think olaparib or rucaparib or PARP inhibitors in general can cause neutropenia in some patients and thrombocytopenia. So neutropenia is what we're concerned about. In my experience, neutropenia is not very significant with PARP inhibitors. So usually the neutrophil counts might drop to, say, 1 to 1.5, which is still within the safe zone. And the next question I have is that, so that probably answered the question for that. The next question I have is, how does COVID-19 affect treatment for gynae cancers? I think Andreas and Dr. Patterson has already answered most of that, in that if we can minimize treatment for recurrent ovarian cancer by using single agent chemotherapy or drugs that are less myelosuppressive, that doesn't drop the neutrophil counts too much, then that would be preferred. If you can have your treatment delayed, then that would be preferred as well. But unfortunately, not everyone can have their treatment delayed. So in the upfront setting where we're trying to cure, say, for instance, stage 3 and 4 ovarian cancer or high risk uterine cancer, that we would still go ahead with chemotherapy and give prophylactic GCSF. So that hopefully answers that question. I will try and minimize face-to-face consultations as much as possible. For instance, in patients who are on maintenance olaparib, a PARP inhibitor can be seen less frequently, perhaps once every 3 to 6 months. And in between times, we will use telehealth and telephone consultations. I would send a blood form to my patients to say to have a local blood test done before the appointment. And we can certainly have a CA-125 done every visit, may it be via telehealth or by telephone. Unfortunately, if you need chemotherapy, you still have to come into your treatment center. You still have to come into usually a day infusional center or a hospital to get your chemotherapy. So that's unavoidable. However, most large hospitals and cancer centers are practicing, all the measures that are recommended by the government, including spacing out the treatment chairs to at least 1.5 meters, to actually screening patients before they walk into the treatment center with questionnaires asking them whether they are unwell, whether they have got symptoms of COVID, and also very soon we'll be introducing temperature screening as well with a temperature probe. So if you're unwell, you're not allowed to actually enter the cancer center, and that protects medical staff as well as other patients in the center having chemotherapy.
Jeffrey, Jeffrey, in the interest of time, can I just ask you one more question, which a panelist just asked me, and then we just maybe need to move on.
Okay, sure.
The question was, if a patient has not had already flu or pneumonia vaccination, would you advise going into a hospital setting or an office to receive one while the crisis remains? Can you answer that briefly, please?
The flu vax, everyone should have it, whether you're on chemotherapy or not, number one. The pneumovax, there is certainly guidelines on that, and your GP can advise you on who should get pneumovax, but not everyone requires a pneumovax. For instance, people with a spleen may not require it. So I think the flu vax is, yes, definitely have that.
Excellent, fantastic. Well, Jeffrey, I'm very grateful. Thank you very much for taking part in this thing. We received far more questions that we can answer. I apologize to everybody who is listening in. It is likely that we will hold another webcast, and maybe we just dedicate that to questions and answers. Jeffrey, I thank you very much.
No problem.
I would like to introduce our next presenter. That's Professor Philip Beale from the Australian New Zealand Gynaecological Oncology Group, ANZGOG. And I invited Professor Beale to present at this event because a number of our listeners and a number of our patients are currently on clinical trials, which we believe is a quality indicator. So some of these questions will probably ask themselves, what is going to happen with the trial participation? Philip, are you on the call? Philip Beale, are you on the call?
He is on the call, but it seems as if we cannot hear him. So maybe if we go to Sandy and we'll bring Philip in by telephone.
Okay, Sandy, are you okay to, okay. Yeah, fantastic, awesome. Thank you.
Okay, can everyone hear me? Will you give me a nod, Andreas, if you can hear me? Yeah, lovely. Okay, let me just get rid of that. Thank you very much for giving me the time slot to talk. Is your screen just the one full slide, or have I mucked things up?
We see two slides.
Oh, I don't want you to do that.
Professor Hayes is by background an exercise physiologist, and we're doing a lot of research work together on the role of exercise in supporting the treatment for gynecological cancer, and particularly for ovarian cancer. And we had a lot of questions up front about the role of physical exercise, what's going to happen with that in the crisis. So I think we are now up and running with the slides, and I hand the microphone over to Sandy again.
Okay, thank you. And Monica and Andreas, well done for coordinating this. I think it would be more stressful than COVID-19. The first thing I really want to point out is I want you to take note that the title of this presentation is How Do I Keep Active During COVID-19, and not should I be active or stay active. And really it's about the how, because we know the answer to the should, and that is everyone who has had a diagnosis of gynecological cancer and possibly either having treatment for their gynecological cancer or having had treatment, all ideally should be doing regular exercise. And we know this from years of research that has really demonstrated all of the good things that people get as a consequence of being active regularly, doing regular planned exercise. Exercise is important following a cancer treatment because it improves things like your cardiovascular fitness, your lean tissue mass, your bone strength. It improves your immune function. It improves your cognitive state. It improves your mood. If you're in the process of having treatment for your cancer, it may help you adhere to your treatment, in particular chemotherapy, and it may reduce the treatment-related side effects that you get. And if not reduce the presence of them, then reduce the severity of them. So I really want to jump to, that's a given. We know that if you've had gynecological cancer, exercise is something that is really important for you, and in fact, probably more important than what it was pre your cancer. Before I move on to talking a bit more about the should I do want to be a bit technical and academic and walk you through this graph that I've done up. Just to orientate you, on this axis, the y-axis, I could be talking about lean tissue, or your heart health, or your immune function, or your fitness. And just for ease of explaining this graph, I want to talk about it in terms of fitness. And then on the bottom axis, the x-axis, what I've added is just events that can happen, and at least for many on the call have happened, including a cancer diagnosis, but then also what has happened beyond a cancer diagnosis. So if we talk about our pre-cancer state, maybe your fitness and 0 is poor fitness and 70 is excellent fitness. Maybe your fitness started about here, and during your treatment, fitness declined. And I just actually need to highlight that I'm talking about an individual who's going along their merry way in a sedentary way, meaning this is someone who doesn't do regular exercise as part of their normal weekly routine. Okay, so fitness is here, they've had cancer, they've received treatment for cancer, and in the absence of regular exercise, we know fitness will decline. There'll be some rebound after cancer treatment has finished, but that point is rarely at the point that it was before a cancer diagnosis. Okay, so we're at a new state of normal, and off we go. We have a holiday, and in that holiday, maybe we've gone on a cruise ship, because that would be the last place you'd want to be right now. But you don't do a lot of exercise and you eat a lot. And so we know that in holidays like that, fitness would decline, you come back to normal. Maybe your activity goes back to a bit normal, your eating goes back to more normal, then you get sick with an influenza, back to normal, maybe eye surgery, back to normal, Christmas, and so forth. And we'll jump to COVID-19, including the first one, which is the government restricting or putting on a whole bunch of restrictions that ultimately are for the majority of us taking away physical activity. Then maybe you actually get sick with COVID-19, and so you can just see fitness is declining. After you've recovered from COVID-19, it'll rebound a little bit. Okay, now I'm going to take away the top part of the figure and show you what someone's fitness would look like if they threw regular exercise into the mix. So if we exercise someone during treatment, we know that we can actually improve their fitness during cancer, and we can get it up even higher once the treatment's finished. We've now got a much nicer new normal, and that new normal means that any hit like a holiday or Christmas or even something like COVID-19 actually is much less than what it would be in the absence of exercise. And in fact, some events like, say, a holiday, it's not a hit at all. So this is really about saying, how do you want to feel pre versus post COVID? And this is hopefully just a little bit of fun. Okay, this guy's pre-COVID. And here he is post-COVID. So you ultimately, to a certain extent, I suppose, get to choose how you want to deal with this COVID-19 period, acknowledging that the government restrictions are more likely to take away our physical activity and also free up our time. And so what I've got on the left side of this slide is just a pie chart that might represent someone's 24-hour period. This someone would be someone who would ordinarily go off to work for about 9 hours. They might sleep for 9 hours. About 5 hours is spent doing some kind of daily activities that may not be too intense or of high load. So things like cooking dinner, putting on the washing, maybe doing a little bit of gardening, and a commute time. We already know just for a very large portion of the population that those who are now working from home, we've gained an hour at least a day in time. And if you did nothing but convert your commute time to time that you did regular exercise, then you could end up in a much better position post-COVID than you were pre-COVID. Now, if only this was as simple as popping a pill, but alas, it is not. If only it was easy to convert our commute time into exercise time. And the way in which the majority of us are going to have to, what we'll need to do to ensure we convert that time productively is we're going to need to plan, and we're also going to need to get creative. Now, maybe not this creative, but I'm showing it just for a bit of a smile. My kids loved it. I told them they weren't allowed to get this creative. We've got a guy here, try training. Okay, you get the picture, but we don't want you don't need to do this. So what do you need to do? What should you be aiming for? Top of the list, top priority is accumulating 150 minutes of planned exercise, and the emphasis is on the word planned. This is not looking for extra little tasks that you can do in your house within your day. This is actually setting aside about 150 minutes of planned exercise of anything. Doesn't matter whether it's walking on the spot, doing some body weight type exercises, if you've heard of something called a lunge or some squats. It doesn't matter what it is, it just has to be planned time, and it can be of any intensity. That's your minimum. The second part is if you can get some of that time of at least moderate intensity, meaning we want you to be exercising so that you're huffing and puffing a bit. Not gasping for breath, but definitely you want to be huffing and puffing, and that you know that you've lifted your heart rate up and your breathing rate up. The third priority is making sure that you include a minimum of 2 resistance exercise sessions per week. And so that means that if you were originally, right now, already very good at going for 5 30-minute walks a week, if you could convert 2 of those 30-minute walks into doing resistance exercise, you've just put yourself up into another position in terms of ticking boxes. Even better is if you added those 2 resistance exercise sessions onto your weekly exercise. The most important point for people who've had cancer and who may be going through treatment is that you need to be guided by your symptoms. So that means if you're going from a sedentary state where you don't do any regular planned exercise, well, don't try and start with 150 minutes of exercise this coming week. You might like to start with every day you're going to plan to go or plan to do a 5 to 10 minute low intensity exercise session. And if your symptoms haven't gotten worse, then you know you've got it right and you can build slowly from there. So the key point is if you have some treatment related side effect, whether it be pain, fatigue, maybe lymphedema, you want to be starting at a level that might be lower than what you think you could do. And as long as your symptoms don't get worse, you know you've hit it right and you can progress from there. But in addition to planned exercise, you also need to be as physically active as possible in as many ways as you can. And this is really about changing mindsets, particularly as we get locked indoors in this period and we become more bored. It's really easy for boredom to breed boredom and we get into this quite sedentary nature. We want to avoid that, and you can do that by being as active as possible in as many ways as possible. So look for activities that you can do within your house. There's absolutely no need to be house proud right now because no one's coming over to visit. So convert your lounge room into an exercise room. Turn on some music, keep things upbeat, look for jobs that you've been putting off around the house and plan to do them. There is plenty of places that you can go on the internet to actually really guide you in terms of doing home-based exercise. And all I've done on this slide is just list some more reputable sites like Exercise and Sports Science Australia. This is the Australia's professional body for exercise and sports science. There's also state cancer councils, though, that have home-based programs that people can follow. And the Ipswich government, thank you to my staff who forwarded this link on to me, has also been uploading some home-based exercises that people can do. But I have to say, if you have a television and it can connect to YouTube, then you will find a whole bunch of examples of activities that you can do. And remember, the rule of thumb is be guided by your symptoms. And I'll just finish by saying I do have an Instagram page. It's called I Can Move It. You won't find me prescribing any specific exercise if you follow me on that site. It's really just about keeping it light and just giving everyone a regular reminder of how important it is to keep moving it, particularly during COVID-19. Okay, that's it from me.
Thanks, Sandy. While you were talking, there was a question. Daily walking is my primary form of regular exercise. Should I continue to do so even though I encounter lots of others, some of whom don't keep a social distance?
Yes, you should keep doing so, but you need to do so while keeping social distance. And I can give you an example. Yesterday, I went for a walk with my husband and 2 of my kids, and the path we took, we bumped into 2 different groups of people who we knew. And as soon as I left them, I said, we need to find a different path, because it really is about, you know, get your exercise, but you don't want to be, you want to ensure you're applying the social distancing rules. And I have to say, if we're on the track that's happened in other countries, we might be forced to stay indoors even for exercise periods. So I would also encourage, start looking at ways in which you can do your exercise within your own home as well.
Sandy, I really liked the guys dancing. I found it highly inspiring. So I think I need to have a word with my wife about how we're going to implement that into our daily routine.
I have to say, I consider, 1, myself a master at working from home, and 2, a master at making sure I can stay active. But COVID-19 has really tested my skills at doing both those things. And so I don't want to make light. I think you've got to set your expectations where they should be. And that is, it's not easy to stay active, but it is highly important. And so you just have to keep at it, keep it forefront in your minds. And as I said, look for ways to be as active and as often as you can. I can only
underline that and confirm that. You know, we're hoping for the ECHO trial data to come through sooner rather than later, and then we will have very, very good data.
Yeah.
Andreas, I think we have Professor Beal now. Hopefully we
Fantastic.
can hear him.
Phil, can you hear us? Okay, I think we're having still problem. Phil, can you hear us? I am very sorry to say that we can't hear you. Phil, you're not.
I'm calling Phil, so I'm calling him, and then we can hear him on the phone.
Okay.
And hello, we can hear you. Hang on, I'll put you on speaker. Okay, can you talk?
I can talk. Can you hear me?
Lovely.
Okay. And hopefully, yes. I'm sorry. I think there's a problem with the microphone in my system. The phone does work, so I do apologise for the technical problems. So, Andreas, I'll start just by talking, from a point of view of trials and patients who are on trials, as the chair of VANSCOG and thinking about clinical trials more broadly. We do know that it's an uncertain time for everyone. I think as a background, I think really to say that we have been meeting regularly to discuss the issues surrounding the COVID-19 crisis, and been very much thinking about patients and their concerns, but also about the investigators and the trial centres. So all of these things are important. We've been having information which has come from overseas, from the trial sponsors, from the coordinating centres, and from the NHMRC guidelines, as well as our ethics committees and departments. So we're certainly being kept busy in terms of understanding all of the needs of the various bodies. So at the moment, what our overall advice is that we have been looking at all the trials, and our view is that for the vast majority of the trials, we believe it's still appropriate that people continue on trials because of the benefit that we believe that the trials will impart to all of those patients. And so we really truly want to continue to do that. There are, however, many considerations, and I'll just run through a few of those. And the first is to understand what the trial treatment actually does entail, and to understand what the possible risks are to patients and how that could impact a patient's requirements for coming to the hospital, possible admission to hospital with any problems or side effects, and really truly trying to work out the overall benefits for patients, but in particular to be sure that we're not going to put people at excess risk. The second is that we understand that really hospitals at the moment are really going through crisis management processes and programs, and therefore resources are being diverted away from standard treatments into COVID programs. But at the moment, we believe that there still are the resources available for all the patients to be able to receive treatments. But, and this is a big but, that is an ongoing review process and will be different in every single hospital across the country. The third is that really is just a matter of staff and manpower. Is that we really just have to understand that each individual trial centre will have staff who could be affected by the COVID virus, and if that is the case, we may well have reduced capacity within the system. And again, that is something that will be really required to be monitored very closely, because of course there could come a time when we have to make some adjustments to our treatment programs. And I think Jeff Go earlier mentioned at least some of the principles behind that, about how we would alter visits to the hospital and could alter treatments accordingly. Within trials, there are exceptional circumstances where we can adjust treatment programs fully assess patients' risk so that we can understand that if we need to change the protocol and the program, we can do that without stopping a patient's recruitment, a continuation on trial, and hopefully to continue with treatment once the crisis has finished. So many of the trials do have a capacity for suspending some intravenous therapy if required for a period of time. And so those judgments are not straightforward, but they're ones that will be ongoing and will be always assessed according to both the patient's needs, but also to understanding the trial and the trial treatment. So, of course, we do have some trials that are continuing to recruit patients because they have been assessed as being substantially at the low risk end to patients, so that the benefit of the treatment is considered to be significant, and the risks to the patient are considered to be low. And I think one of those examples is one of the trials that Sandy Yates is the lead investigator of, which is an exercise-based trial in the treatment of ovarian cancer. But some trials we are putting on hold, at least over a short period of time, so that we can truly understand what is going to happen with the changing nature of the health environment over the coming 2 months into the beginning of winter, and then really to make reassessments on a regular basis so that we can be sure we are making the right decisions for all patients. So, Andreas, I don't know if I need to say much more now, other than really that we are truly trying to be mindful of everyone's needs on trials. We are really assessing things on a weekly, twice weekly basis, so that we can be sure that we are ensuring both the safety of patients, but also ensuring we are allowing patients to continue on trials to obtain ongoing benefit. We're happy to answer any questions.
Thank you very much, Phil. My understanding is from what you said that you want to maintain trial activity to the best of our abilities as long as it's safe. We may need to modify the one or the other thing. We may result more to telehealth, but in principle, you can see the trial activities will continue. If patients have specific questions about their trials, and in particular, how patients will get to their site, or if patients ask themselves if they need to get to the hospital or to the clinic or whatnot, I'm sure they could contact their local trial coordinator, who is typically the person who the patient has regular contact with. Certainly at QCGC, we have each trial has a trial coordinator, and the patients know exactly which one of my staff is looking after them. So that would be maybe advice. Would you agree with him?
Yeah, no, I totally agree. I think that obviously study coordinators are a very key group who will have their connection with patients, and I think that the communication broadly to those study coordinators so they understand where trials are, I think is also incredibly important from an organising point of view. Lovely.
Well, I thank you very much, Phil, for taking the time to join this call. We were well aware that there were questions from patients about clinical trials, because a lot of our patients are on clinical trials, which is a fantastic thing. Thank you very much.
No problems, Andreas.
Monica?
Thank you very much. So I think our next speaker is Tracy Gardner, who very kindly joined us from the Cancer Council Queensland to talk a bit about ways to manage mental stress. And I will ask Tracy to start her video. And there she is. Perfect. Thank you.
Hello, everyone. I will keep this hopefully to the 5 to 10 minutes that I've been allotted, because I know that it's getting late and everyone needs to get home and on with their evening. So I'd just like to acknowledge, first of all, that everyone present knows that having a cancer diagnosis is a major life stressor. And in addition to this, the current pandemic is very likely adding to the stress and the uncertainty that patients and their carers are already feeling. And these feelings of worry and uncertainty are a very normal response to a stressful situation. And you may not be aware, but the primary reason that uncertainty is such a stressful experience for human beings is it's because it erodes our sense of self-control. We all like to have a sense that we've got some control over our lives, and those two, having cancer in your life and having a pandemic, is a double whammy. Yet despite the impact of COVID-19, and particularly in the context of a cancer experience, there are a range of strategies that you can use to take care of your emotional health and that can increase your ability to cope with the many stressors that are arising. And many of these strategies are skills that we regularly suggest for people in responding to a cancer diagnosis, to cancer treatment and recovery. They are also skills that we can apply in the current circumstances. So I'm going to talk about some helpful ways to focus on the aspects of life that are within your control. And this focusing on what we can control is the most important coping strategy we can adopt. So the first one of those is being proactive about our well-being and protective measures that we can take. This really helps to lessen feelings of anxiety. So following those basic hygiene principles that were mentioned earlier and the measures that have been recommended by the World Health Organization. The steps that you take towards this is under your control. And where you have particular questions about the impact for your situation with cancer, contact your treatment team and look for that guidance and advice from them. Staying connected is incredibly important. So social distancing doesn't mean social disconnection. So maintaining positive social connections is really important, and using those methods that we're all familiar with, phoning, FaceTiming family and friends, emailing, text messaging, or just spending quality time with the people that you live with. It's probably also important to spend some time away from the people that you live with. So it's perfectly okay to say, I need some space to myself. Be intentional about catching up with people. So if you're thinking I might phone a friend and have a chat, making an appointment in your diary, just like you would if you were going to catch up in a cafe under normal circumstances. And if you're particularly socially isolated, as some people are, get in contact with services like Beyond Blue and Lifeline. Also practicing self-care, your own self-care, is an excellent buffer to the impact of stress now and always. And it's a very important way of dealing with uncertainty, because one thing you can control is taking care of yourself. Adding variety, adding flexibility, just as Sandy was saying with exercise, is also really important. And making sure that you do things that you enjoy. So Sandy covered exercise very well. We know that it boosts mood, improves your sleep, and generally reduces stress when we exercise. I'd also just like to acknowledge that for some cancer patients, they can't do either what they normally do in terms of exercise, or they can do very little at all. Even so, doing something like yoga, Tai Chi, and again, you can access these quite easily on the internet now, some simple how-to courses and steps, might be something you can do in the interim until you can return to your usual program, or till you can build up to doing the wonderful program that Sandy recommended. And then there's almost another layer of people who might be recovering from surgery and can do very little at all. So in that case, even doing deliberate relaxation exercises is really important for reducing your stress. It gets your mind off what's going on in your mind and puts your mind onto your body, which gives you a little break. So Cancer Council Queensland has a relaxation CDs and links. If you go onto the Cancer Council website, you can access those, or by calling 13 11 20. Healthy eating is also extremely important. It sounds like a cliche, but we actually know in terms of managing stress, managing uncertainty, when we put the right fuel into our bodies, it actually increases our ability to cope. Conversely, sometimes when we're under stress, we all reach for the junk food. That actually undermines our ability to cope, and in particular, alcohol. Whilst we think alcohol might give us a bit of a mood boost, it actually depresses our central nervous system, and that's the last thing we need right now. So either having no alcohol or just limiting it to one drink is helpful. And likewise, caffeine can have a substantial effect on your mood. So just watch how much caffeine, how many cups of coffee you're having a day, because that can speed your heart rate up, and for some people make them feel quite jittery rather than relaxed. So the other thing that I think is really important, and it doesn't cost anything, you don't have to go on the internet for it, but beginning to think about practicing gratitude, which can sound like an odd thing at the present time, but if we start to cultivate the practice of thinking about what we're grateful for, that also is a way of shifting the focus of our attention from worries into what we know is certain. And we know that that's helpful. So some simple ways you can do that is start a gratitude journal, or simply think about 3 things before you go to bed at night that you're grateful for that happened in the day, or that you're aware of in the current moment. And it might be that you're able to get some fresh veggies. It might be that when you walked in the garden, you noticed a flower blooming. Also practicing helpful thinking. So it's very easy when we're under stress. Our thoughts will often run away with us and we think about the worst case scenario. So a helpful practice is beginning to become aware of the content of our thoughts, where our thoughts are going. Just noticing and acknowledging that we're having worrying thoughts, understandable. Just taking a step back from that and taking a few deep breaths and asking yourself some questions. Am I getting ahead of myself? Am I worrying about something that hasn't actually happened yet? And am I actually underestimating my ability to cope? As an adjunct to that, I just like to also say it's really important that we mind our language, because again, our brain is very good at warning us about everything that could go wrong, might go wrong, and we can easily catastrophize things. So watch that you're not saying this is awful, this is horrible. Your brain's listening to you say that. So much more helpful to say, I'm cultivating ways of coping. I'm looking at ways of increasing my ability to exercise. I'm looking for nutritional things to eat rather than focusing on what's not going well. And then bringing your attention to the present moment is an extremely powerful way of taking control. So often our mind will go back to worries about the past or worries about what might happen in the future. Both of those areas are completely out of our control. But by bringing the focus of your attention into what you're doing in the present moment, whether it's having a shower, noticing the warmth of the water on your skin, the smell of the body wash, the sound of the water going down the drain, and the touch of your hands on your skin, bringing your mind fully into whatever you're doing in the present moment gives your mind a little mental holiday. And you might also notice some of the special moments of the day that otherwise slip by because we're on autopilot doing things and carried away with our thoughts. So cultivating that habit is a really, really helpful one. Also structuring your day. So if keeping to a routine is helpful. Planning, if you normally like to do your work in the morning, keep doing your work in the morning. Use your calendar, use your diary to make appointments with yourself, for going outside and getting some fresh air, catching up with a friend. Limiting your media. So while we all want to stay abreast of all the developments that are happening, thinking about how much is useful to know and how much is too much. So if you imagine as though you were looking over the shoulder of a child, watching the television, watching the internet, and just asking yourself, is this helpful information for me to be taking in right now? And if it is, then by all means keep doing it. If it's not, if it's starting to distress you and you're feeling overwhelmed, then turning it off, changing the channel in your life in that moment and finding something more proactive to do. Social media is incredibly important. I think Andreas mentioned that before, but it's also the social media that is helpful. It's important to focus on. And if you notice that something's not helpful, again, changing that channel, metaphorically. So experience of the last few weeks has obviously shown that, you know, what people are thinking often has no factual basis. We know that thoughts are not facts. So the supply or need of toilet paper hasn't changed. However, misinformation about it led to community distress. So taking a step back as much as you can when you hear information and asking yourself, is the source of this information reliable? And where can I seek the most accurate information? So it's places like the World Health Organization, the Australian Government's Department of Health website, places like Cancer Council Queensland, Cancer Australia, and of course your treatment team. And finally, I'd just like to finish up by saying, if you do feel overwhelmed, if you do feel like you're not coping as well as you know you'd like to, then do discuss how you're feeling with your doctor, or call 13 11 20. That's Cancer Council old helpline number, and now we call it 13 11 20, just to discuss how you're feeling, discuss perhaps accessing the cancer counselling service. We're a free service, and we're moving completely to telehealth in the current climate, and very much still keeping our service going. So each of these strategies and suggestions help to shift the focus of your attention from worry and uncertainty to taking practical action, doing practical activities, engaging in some helpful ways of thinking that increase your sense of control and very much help with coping with stress. Thank you.
Thank you very much, Tracy. I really liked your analogy with the toilet paper and how there wasn't actually a shortage, but the thinking about it made it a problematic issue. So thanks so much for sharing your thoughts there.
Welcome.
Thank you, Tracy, and I really appreciate you making yourself available. The number again that Tracy said is 13 11 20 13 1120. That's a helpline for people who need a helpline. I now come to a part of this webcast that makes my heart a bit racing, I must say. So I welcome two of my colleagues. These are colleagues who are close to my heart. I love them both, and they know that. One is Alessandro. Benvenuto, Alessandro. He is from Italy, and Alessandro, it tore my heart when I watched all these terrible images, and I get goosebumps when I just think of it. And Alessandro was in Brisbane only a couple of months ago, and we had so. Anyway, Alessandro, how are you going? How is your family going? And how are you doing? We have an enormous number of people here on the line who want to know how life in Italy is happening at the moment.
Andreas, good morning. Thank you for the invitation. It's unreal because it was about 2 months ago I was there, and the situation was going to start from China to Europe. I remember when I was ready to come back to Italy that my wife told me, take care and stay safe in the airport because there are some voices coming from people who's moving all around, and it seems so far to me. I'm okay. You know, it's winter here. I had some cough, but you know, you never know what happens because the problem also now, one of the issue we discussed in Italy is about maybe all over the world, it's do we have to perform, you know, the test for the COVID to all employers or people that are at home asymptomatic like I am, like my family, but it's okay. We are okay, and I think what I feel, what we are learning, I think to me, what I'm learning from this situation that changed very, very quickly in Italy, it's drama, you know, but I feel this is the challenge that this time is proposing to us to live. And, you know, we must be able to cope with this, but whether we are prepared or not, because it's impossible to be prepared to something like this in the hospital. I mean, I'm very lucky because as Department of Gynecology Oncology, we are at the edge, you know, of the drama of the intensive care unit, but we are covering the obstetric department, and we have only at the moment here 6 women, pregnant women that have the COVID, but women, you know, with pregnant have only limited symptoms of COVID. It's strange because child and women pregnant are with mild symptoms, so it's okay to me. But I see all around, you know, the corridor of the hospital, all the guys and colleagues that works in intensive care that completely changed their life, and the hospital is full of people. Now we have, for example, in Monza, 450 COVID patients and more than 50 beds. We are on track with 40 more beds for intensive care are completely occupied by those very critical patients. So the situation is it's very hard, but I mean, at home is I can tell you just one thing that you know that my daughter is at the high school, and everything changed quickly from one day to another. But now we are performing lesson with the Google lesson program. It works, and likewise, also she makes music lesson with the computer and also English lesson. And I asked her, what do you feel about that condition? You know, you have to stay at home, you can go outside just for a few minutes during the day. But she said, oh, it's okay to be. Nothing changed in a very big way for younger, even if they can have, you know, contact with the other students, and they can go outside for sports and all the things. But I think it's something important also for us. We are, you know, our culture, you know, it's particular, but we are adapting to this situation. And if you go slowly, like we are doing now outside the hospital, for me never changed. The situation changed, but you know, every day I go to the hospital, I come here and I work. It's all change all around us, but you know, this is my life. Most of the day I'm in the hospital, but at home something changed, because sometimes, you know, you have the chance to stop and to think about the most important things of life. And I think this is a good lesson for all of us, not only here in Italy, but all around the world, I think.
Alessandro, did you get sick?
No, never. I never have a fever, but I had some headache 2 weeks ago. And I felt, you know, like we don't feel completely fit, but it was nothing important. And I don't know if it was the infection of the virus, but nothing important. I didn't have any problem. Some colleagues, yes, of course. And I can tell you just a number in Bergamo and also in Lombardy, more than 14% of health operators has infection, and they can't go to work. So it's a big number, you know, more than 400 doctors and nurses are involved with the infection. So it's now it's a problem, because you know, we miss doctor and nurses also, and also young doctor has been recruited for helping. They can do, you know, they need a teacher, but a lot of young doctor is recruited for this emergency.
Do you still perform emergency surgery?
Yeah, you know, all the elective surgery has been, except emergency. Some oncological surgery has been stopped to leave bed and to also the department for the emergency. And but the activity was reduced to 80-90%. I think we operate just 1-2 days during the week. And the emergency, of course.
Well, Alessandro, it's really good to see you well. I mean, you know, what can I say? It's I guess in times like this, we just hang on to the one that we have, and you know, and I'm really happy to see you. And if people have any questions to Alessandro, then I'm happy to take them.
Sure.
In the meantime, I would like to introduce Dr. Joe Ang, incredibly generous colleague from Singapore, who I serve with on the IGCS Council. Joe, how is Singapore going? What we hear from the news is that you guys have such excellent data that seems to be so different from Italy. Joe, how is life in Singapore?
So, hi Andreas, and hi everybody listening. So I guess I'm just going to present the hopeful side of COVID-19. So I'm just going to keep talking while I'm going to share a bit of a screen here. And do that. Yeah, can you guys see the screen at all?
Yes.
Okay,
Yes.
so I'm just going to keep talking because I think the key here to surviving COVID-19 is cooperation. We're all going to do this together. No government or no institution, no doctor is going to be able to help the community survive COVID-19. It truly is a community effort. So I'm really impressed by Andreas's kind of vision and foresight and kind of putting this together to get the word out to as many patients as possible. Because again, like I said, if we all cooperate, we're all going to get through this okay. And evidence for that is in Singapore, because since the early days, there have always been fairly, it's been a calibrated approach. So I think there has not been a huge jump from life as normal to total lockdown, primarily because incremental steps have been taken along the way. And really just 5 simple steps: managing your health, keeping your hands clean, always keeping in mind that, again, COVID is not an aerosolized, it's not out in the air. This is a virus that is in infected droplets that are in contaminated hands. So you touch them with the surface, you touch contaminated surfaces, and then obviously anywhere from 20 times a minute, you touch your face, and that's how the virus accesses your mucous membranes, and that's how people get infected. Certainly minimizing contact, but minimizing contact with those who are unwell. So I think everybody who's been unwell has been very, very cooperative in terms of staying home very early on in the game, which is how Singapore has kept the infection curve fairly flat. I mean, I think cases only started to spike in middle of March when people returned from holidays. So now there's a travel ban, there's a total travel ban. So, and of course, anybody who's flown through Singapore will know that Singapore is a travel hub. It's typically very, very busy now. It's just in Changi Airport the other day, and it's a total ghost town. So it's, again, it's unusual times, but I think we're all going to make it through if we all do our part. So that's really my message, because life in Singapore goes on as usual. I mean, we're still going out. Of course, everybody tries to go out as little as they can, but most of the stores are open. Some restaurants are open. The only things that have been closed recently are bars and night spots that have been closed till the end of April. But life goes on, and everybody's responsible.
So Joe, if I understand you correctly, so in Australia we discuss enormously about whether draconian measures are effective, and some people request a lockdown, a total lockdown. A total lockdown is quite likely to come because the social distancing is voluntary and is not as working as well and as effective as it probably should. Do you have a total lockdown in Singapore?
No. So, like I said, I think life goes on as per normal in Singapore. So businesses are still running. The only places that have been shut down completely are night spots, so bars and nightclubs, lounges, that sort of thing. But restaurants are still open to serve food. Obviously, the seating in restaurants has been significantly decreased because of distancing requirements. So tables are required to be at least 2 meters apart. But I think I would recommend, or I would be the voice of reason in all this, because again, like I said, I think if everybody takes a very calibrated approach in a stepwise fashion, there's really no need to ever get to a point where you have to do a Wuhan style lockdown.
Okay. Alessandro, are you still on the call?
Yes, I am.
Hey, Matt, is there anything we can help with? I hear your despair, and I think everyone on this webcast feels with you, especially the ones who know you personally and know what a generous and kind person you are. Is there anything we can do?
Oh, I think I don't know. There are a lot of people here are doing a lot of things, and it's donation and all devices for the intensive care. The problem is that you never know when happens something like this. If you read to the newspaper here in Italy every day, or you look into the TV, there are some journals that say, okay, the government is not good. They have to do this. They didn't do this from Monday, from January, and they didn't do nothing. But the problem is not today. It was not on January and the last month. And on this situation, you will never be prepared to do everything you have to do in this situation. The problem, for example, in Italy, from my point of view, is that what in the last 20 years they didn't do or we did for the healthcare system. And I think that the most important thing is that from this disaster we can learn something, to restart thinking about, to redesign the way we can deliver care for patients. For example, the emergency room or the outpatient ambulatory are full every day until the last months. But now we have only few patients, oncological patients, people that have, chronic disease that had to come for tests in the hospital, and we can discuss which of this can do outside the hospital, this test. And but most of the people doesn't come to the hospital, of course, because, we have restriction, but most of them, in my opinion, a lot of people can avoid to come to the hospital, because we have to think about how the disaster could be averted by applying new models of medicine for the future. On New England Journal Catalyst, Innovation in Care, I think the group of Bergamo wrote this, and I have also, I can send you the reference of this paper. And this is interesting because the new model, because the question is, I think, in my opinion, that they rise to the community is, are these things we are doing now that will be part of the new normality for when the epidemic condition, the COVID emergency will end? Yes, for sure. Maybe it will cost a lot of money to the government to redesign the healthcare system. Also here in Italy, it's not bad. In Lombardy, it's amazing, but emergency, for example, beds are missing, respiratory for that now we have, because now in the hospital we have 90, but usually we have 15, 19, 50. It's completely different. We don't need 19 for sure in the next few months probably, but maybe 15 are not enough. When we have to think about this, I don't want to say pandemic condition, but emergency condition that maybe would come in the future, and maybe home care, mobile devices, telemedicine instruments. I think these are the most important lesson that we have to learn about that, and how to manage patient to avoid and to limit the hospitalization. I think that should be focused on target subgroup of patients with different severity, and so thereby decreasing the patient, healthcare workers and doctors, and to avoid infection and contagious. Also minimize the consumption of instrumentation, devices, equipment, and also drug. We miss drug in this situation now in the intensive care department. You know, Curaro for anesthesiologist, and I can tell you a lot of examples from this, but you know, we have to think about how to redesign the way we deliver care for our patient. And the nicest thing to think about is to keep in touch, and also to meet somewhere in the next future, because it's one of the things I think people here and all around are starting to miss now, the contact with the other. But I think you know, computer like connection like today, it's amazing, and we can keep in touch like we couldn't did in the past. But to me, the contact of an ag, and you know, meet people and colleagues, and stay together, it's something we are going to starting to miss now.
Thank you very much, Alessandro. Thank you very much for making yourself available to give us a first-hand account of a very, very severely hit area of the world. Joe, are you still on the call?
Yep, right here.
Would you be willing to basically summarize what you think that what we can learn from the Singaporean example, and what, in your opinion, we should do?
Yeah, so I think for Australia, and for the audience that's listening right now, for your patients, I think there was a question right now about why the situation is so different in Australia than it is in Italy. And I think the reason is because Australia is just kind of seeing the beginning of that curve, the infection curve. So there's still time to kind of get ahead of it. So I think if everybody does their part, there is a good chance that you'll be able to flatten that curve and reduce the rate of infections. People can get sick. I mean, the key here is not that COVID's a very deadly disease. COVID's a deadly disease only when hospitals are overwhelmed. So there's good data from China that suggests that if you get sick with COVID, but you're in a hospital that's not overwhelmed, you do pretty well. And that's the early data from China. So when they were able to ramp up capacity, that solved a lot of the problem. So I think it's turning off the tap, as well as kind of managing things in hospitals. So for the healthcare providers in the room, we've all had to make sacrifices to cut back on our elective lists, to free up resources to be able to, for the hospital to care for sick patients. And then in the community, I think it's minimizing contact. You can still go out and have your exercise, but you know, again, wash your hands and don't touch your face. Simple things. If everybody does them, we're all going to be okay.
Okay. Well, thank you very much for sharing your experience with us. I mean, you know, you've done pretty well. So I hope that a lot of people listen and implement these things in their daily lives. Those 5 things that you said, including, you know, keep apart, wash your hands, wear a mask if you're sick, and whatnot. So I would like to thank all panelists and all presenters for coming to this webcast. I'm incredibly grateful for your time and for your generosity to share your experience. I would like to thank the people who were on the call because otherwise we wouldn't do this, and I hope it was interesting for you. Interest pending, we are happy to put this on again, maybe with more focus on questions. I would like to thank the QCGC research team, including all our QCGC research staff who worked incredibly hard over the last few days to pull this off. I walked into the office on Monday morning, and I've thrown this into the lap of a few people, and I'm very grateful that you guys took the challenge and made this a reality. And I'd like to thank my co-chair Monica, and I wish us all well. And again, thank you very much for your generosity and being on the call. A recording of this will be made and will be available on the QCGC research website. Thank you very much, and good night.
Night,
Good night.
everyone.
Bye bye.
Good night, all.
Bye, Monica.
Bye, Alessandro. Bye.
Take care.
Bye.
Take care, you too. So there was a question where the recording will be available from. It will be available from the QCGC research website, and probably also the Cherish website from next week. We just have to edit it a little bit.